Welcome to the St Mark's Hospital podcast. I'm your host, Peter MacDonald, one of the surgeons here. And as the UK's only specialist bowel hospital, endoscopy, of course, plays a crucial role in patient care at St Mark's. The Wilson Unit for Endoscopy, as it's called at St Mark's, is world-renowned, being the only unit in the UK to achieve the World Endoscopy Organisation recognition as a centre of excellence for endoscopy research and training. Today our guest is Dr. Siwan Thomas-Gibson, who is a gastrointestinal endoscopist and luminal gastroenterologist. She's been a hospital consultant at St Mark's since 2006 and recently has been appointed Dean of the Academic Institute. She was awarded MD at Imperial College with her work on improving training and assessment in colonoscopy, and is very much involved in JAG, which is the organisation which controls endoscopy in the UK. She's published many papers, and her clinical interest is improving endoscopy training as one of the central features, and this will form the basis of some of the podcast today. Welcome, Siwan, and I think we might, first of all, if you'd like to just say what the Wilson Endoscopy Department is, roughly, and how big it is.
Yeah, thanks, Peter. I'm delighted to take part in this podcast. So the Wilson Unit for Endoscopy has been at the St Mark's site long before it came to the Northwick Park site, but in its current status, we're a 6-roomed unit, and we perform across on this site around 25,000 endoscopies every year, and that number's increasing. But I think what we're most proud of and most famous for is the teaching and endoscopic research that we do in the centre. And that's a combination of hands-on teaching in the form of train the trainers courses, particularly in colonoscopy, but also in therapy like polypectomy, for example, and more recently even advanced therapeutic training courses with Professor Saunders with teaching endoscopic submucosal dissection.
So people will come from all over the country and even the world to learn some of these techniques here?
Yes, absolutely. We have our own, obviously, in-house, both medical and surgical and nursing trainees. And then we run very many courses throughout the year. So we'll have, in a typical year, into the hundreds of trainees coming to learn all modalities of endoscopy, mostly lower GI, which is, of course, what we specialise in this colorectal hospital.
Indeed. And you said the number of patients coming through here are very large numbers. I mean, how does that compare with other units up and down the country?
So we are one of the largest endoscopy units in terms of the numbers of patients that we see. Without getting into the local politics of it, we're not particularly large in terms of our floor plan and the rooms that we have. As I say, just 6 rooms, but we also run endoscopy lists. We have general anaesthetic lists every day of the week. Some in endoscopy, some in theatres, and of course in radiology. We run evening lists and we work throughout the weekend. So we've really had to maximise our capacity, which is very similar across the country, particularly with the introduction and rollout of bowel cancer screening.
So there's this growing demand for colonoscopy in particular up and down the country and worldwide. You'd mentioned for a moment general anaesthetic endoscopy, colonoscopy. What are we doing? What are the special lists that we're doing that might be different from certain other places?
So I think the vast majority, as you know, the huge majority of patients who have colonoscopy will manage with either conscious sedation or indeed no sedation, and many patients are surprised to hear that. And here we would perform up to about a third of our patients having colonoscopy without any sedation whatsoever, or perhaps just Entonox. And then the vast majority, as I say, will have intravenous sedation. And then a small minority will have general anaesthetic or very deep sedation administered by an anaesthetist in the form of propofol. And those groups of patients are either those who have complex anatomy and therefore colonoscopy is very uncomfortable or technically very challenging. So that's one group. And then the other groups are the therapeutic colonoscopies that we do. So perhaps, as I say, advanced endoscopic mucosal resection that's going to take perhaps more than an hour, or an ESD similarly, or some of the polyposis work that our colleagues, Dr. Suzuki and Dr. Andy Latchford, perform for patients perhaps even in the upper GI tract who are having advanced upper GI therapy.
And double balloon enteroscopy is also...
Yes, so we have a weekly, Dr. Adam Humphreys performs double balloon colonoscopy, either orally or transanal route, and they are mostly done either under deep sedation or general anaesthetic. Some of them are done under sedation, but so there's a whole raft of procedures that are performed that are requiring support from our anaesthetic colleagues, and again that's mirrored elsewhere in the country. But of course we have a specialty group of patients here who require that. Indeed, because we see those where other centres either don't have general anaesthetic, or indeed because the procedure for some reason is technically challenging and therefore we need additional anaesthetic support. Most patients will tolerate colonoscopy for up to about an hour. If a procedure is predicted to go for over an hour, then I think in general we would try and offer deep sedation or general anaesthetic.
And going back to the vast majority, you either have no sedation or light sedation. We rather pride ourselves in, and I know Christopher Williams used to talk about it a lot, of doing as little sedation or as light sedation as you can for safety reasons. Do you want to comment on that? Because that may come to as a surprise to some people listening, that we do use really as light sedation as we possibly can.
Yes, we do. And I mean, the first thing to say is I think the patient's choice has to come into this. And in order to have choice, they have to have information. So I will always say to a patient they have these 4 options. So absolutely no sedation at all, or Entonox, or a combination of usually fentanyl and midazolam, or anaesthetic delivered sedation or anaesthesia. And there are pros and cons, of course, to all of those, both in terms of safety for the patient and patient convenience and experience. Clearly, if a patient has no sedation or Entonox alone, they can leave the department very much more quickly and be back to perhaps work or picking up the kids from school or whatever it is that they need to do. But they need to understand that they're then going to be completely aware of what's going on. And of course, actually unsedated or lightly sedated colonoscopy is in general much easier to do because of some of the technicalities of it. For example, patient position change will make things much easier. But we are, of course, facing a more comorbid and elderly population as well. And so those patients, if they can tolerate very little sedation, it is safer. If we do use sedation, then again, it's a bit more onerous for the patient. The patient has to have somebody to collect them, to take them home. And really, most patients, we would say, should have somebody with them at home. They can't drive for 24 hours and so on. So it interrupts their schedules very much more, already having had their schedule interrupted because they had to have bowel preparation from the day before. And obviously, older and more comorbid patients may not respond to sedation as well as younger people. So, we try and keep sedation to a minimum so that it's safe, but the balance is obviously making the procedure tolerable for the patient.
Right. Now let's talk about the difficult colonoscopy, because, for many people listening, the ability to do a quick and easy colonoscopy is sometimes their biggest challenge in their work. And not all colonoscopy is easy. And there are many tricks. You've mentioned one already, which is the light sedation, which allows you to turn the patient, which makes a huge difference, as we both know, for colonoscopy. What other tricks can we develop, have we developed here perhaps more than other places, to help a successful colonoscopy be achieved?
Well, we could probably spend an hour or more just talking about those. I think I would go back to having the opportunity to talk to the patient beforehand, and that might only be, you may only meet the patient immediately before, at consent of course, because they may have seen somebody else in a clinic, or they may indeed these days have been sent directly in from their GP. But having that conversation with the patient up front, I can't underestimate how important that is. So a patient needs to know that they are in control, and if they're not coping, that they can say and interact with you, and that they understand that they're going to perhaps feel some discomfort, but if at any time it becomes painful that they can let you know. I mean, pain is sometimes, unfortunately, part of colonoscopy, and it doesn't mean that something is going wrong, but we should have all of the tools available to try and ease that. So patient position change, without, again, going into the detail, is very helpful. Although one of the things that has changed my practice in the last couple of years really has been to use water rather than gas to inflate the colon during intubation. And for that, you don't really rotate the patient. In fact, it's important to keep the patient in the left lateral. So that's something that we're changing in terms of our technique.
Let's talk about that very briefly, because it's relatively new.
Yes.
Are you using it for all colonoscopy now, or just where you expect some difficulty?
No, all colonoscopy, I now use it. So we've moved away, as you know, historically from using air to inflate the colon. Really, no one should be using air at all. And for many years, we've been using carbon dioxide, and certainly this unit has published on that, you know, when it was first being used. And that made colonoscopy very much more tolerable. But of course, any gas will inflate and elongate the colon and make the angulation, at flexures more pronounced. Whereas if you use water through the sort of more modern scopes, many of them have an integral water flushing system that makes it very easy via a foot pump to put water in. So I switch the gas off completely, put the scope in, and then just infuse water just enough to be able to see where I'm going. It does rely on there being good bowel preparation, because if the prep isn't very good, then you get a very murky view. And there are a couple of great reviews of this, most recently in Frontline Gastroenterology this year, looking at an overview of these techniques. There are different techniques described: water immersion, water exchange, but the basic principle is that you're using water, taking out the gas as you go in, really until at least you're in the transverse colon. And if you think about it, the water will weigh down the left colon and reduce the angulation, and you essentially swim through the colon. And usually when you get into somewhere in the transverse colon, then perhaps position change or the use of CO2 may help you complete the procedure. But it's certainly helpful in very fixed sigmoid colons. It's very, very helpful in those long colons. So
is it particularly good in someone who's had a hysterectomy, which is one of the old bugbears of an easy colonoscopy?
So fixed colon for any reason, just because it really is just weighing the colon down and minimising the amount of stretch within the colon.
And you're using water, not saline.
Correct. Yes.
Right.
Yeah.
And what about cuffs and caps and things like that? Because they're relatively new, and an ordinary person who's doing a lot of diagnostic colonoscopy may not use these things very often unless they get very, very difficult cases referred specifically to them. So
so cuffs and caps historically were developed to try and improve the views on extubation, particularly. So cuff, which has a number of soft prongs on it, is designed to flatten out the folds during extubation to improve your pickup rate for polyps. But actually, and transparent caps, again, were traditionally or originally developed to, again, flatten out folds and stabilise the area for therapy. But actually, both of these devices have also, in some studies, been shown to help with intubation. The cuff, it's thought, probably anchors the colon and allows you to pull back and straighten. So rather than falling back when you're straightening a loop in the colon, it provides some friction and anchors the scope. And so there is limited evidence that these devices can also help with intubation. But of course, there are some contraindications to them as well. So we don't use them routinely.
Right. So it might help you take a loop out if you've got something like that. Because that's one of the things that we're always trying to do, aren't we? Certainly when we did more gas colonoscopy, the loop was the real bugbear. Do you find you don't really find that in the water immersion?
Much less so. So the literature does suggest that you do get less looping. I wouldn't say that you don't get any looping, and of course there will be some colons that still will loop, but it does minimise that. And the cuffs, I would just go back to the cuffs and caps, because I wouldn't want people to to think that we're recommending that they use them in all cases. Water, yes, there's virtually no contraindication to using water. Obviously, you'd have to be careful in cases where there's risk of fluid overloads, perhaps in renal failure patients or cardiac failure patients. But cuffs and caps, they're probably of use in screening type patients or patients who are going to have small polyps. They're going to be of use in patients who've perhaps got a polyp in a difficult, in an area difficult to access, or where it's been difficult to visualise the polyp previously, or where you're hunting for a polyp that's perhaps been seen with imaging. But there are some contraindications. It can be tender going in through the anal canal using a cuff or a cap, and through a very tight sigmoid diverticular segment. I would caution use, or in active colitis. I would avoid it.
That's very useful. Now, one of the things that you've spent a lot of time doing is training and trying to get the training systems applied properly around the country. How has training changed, and how do you see it going in the years to come?
Again, that's a really big question. I mean, training has changed in the UK such that, now we are really recognised as leaders in terms of how we've developed training. And before the rollout and the start of bowel cancer screening, a huge investment was made in training programmes. And the ethos really was that investing in training trainers to teach at grassroots level, to improve their teaching at grassroots level, not in an entirely uniform way, but speaking so that the same message was given to trainees as they moved around from post to post. And so investment was made both in basic skills colonoscopy courses, if we just take colonoscopy as the example, and in training the trainers to teach that. And really now trainees coming through are of an incredibly high standard, and there are protections in place such that no longer are trainees left unsupervised. They really are supervised closely, hopefully by a trained trainer, until they themselves are competent. And their training is logged on what we call the JETS portfolio, so that they build up their competencies, and then when they have reached competence according to the trainer's assessments, they will be ready for certification.
And that's the National Endoscopy Training System, the JETS.
JETS, yes, through JAG.
Part of JAG.
Yes.
And have we seen a reduction in complications nationally following all this? Can we measure that?
So I think a reduction in complications is difficult to demonstrate. What we have seen is that the two big UK national audits, Jane Bowles' paper, which really reflected, it published in the early 2000s, but it reflected data from the end of the 90s. There's been a sea change in terms of quality of colonoscopy, in terms of completion rates and polyp pickup rates and so on, and the degree of supervision of trainees. We would hope that has also demonstrated a reduction in complications. It's difficult to measure that in terms of trainees, because trainees, obviously, if a complication happens with a trainee currently now, that would be attributed to the trainer rather than the trainee. But certainly the quality of colonoscopy in the UK has improved for sure over this period where training has become more structured. I think the biggest challenge for us now is that the ever increasing demand for colonoscopy means that we're going to have to get smarter about training. There's a reduction in the number of years that certainly gastroenterologists are going to be training in colonoscopy, so we're going to have to cram that training into an ever shorter timescale. And of course we have a huge cohort of excellent nurse endoscopists who are also being trained in colonoscopy, and the challenges are to try and speed up without losing any of the quality, speed up the training programme, and that's something that my colleagues in JAG are working on now.
Right, and I suppose as we're doing more advanced procedures, more ESD and EMR resections and so on, we might still see some of these complications, perhaps more than we would have done if we sent them straight to surgery, which in a sense has its own complications. How ambitious are we getting with these very large adenomas, right-sided or rectal? We're now doing things which we 10, 15 years ago wouldn't have dreamed of doing endoscopically, and it seems to be extraordinarily successful. Do you want to comment on that?
Yes, I think, it's a new branch of endoscopy, really, and it's really, they are endosurgical techniques, and quite literally some of them are combined endosurgical techniques. And, the overlap of for example, in the rectum, the overlap of the techniques available, they're still all trying to find their way in terms of the evidence base for them. But it does mean that there are a variety of options for each and every large lesion that we see. And I shouldn't just use the word large lesion, because sometimes it may be an early invasive small lesion. And we have now everything from full thickness resection devices that sit on the end of a scope, so you can literally remove either a small cancer or a recurrent polyp from anywhere within the colon, full thickness, and seal it in one go on the end of a colonoscope, through to, as you say, endoscopic mucosal resection and ESD, and then into the sort of combined procedures or transanal procedures, taser and so on. Many endoscopists want to get involved in these more exciting therapeutic procedures, but I always say that really you have to go back to basics. You have to have the basic polypectomy skills up your sleeve before you can think of embarking on them. And there is an increasing demand. Screening will pick out these more advanced benign lesions or very early cancers, and it's an incredibly exciting field to work in. The challenge, as you've already alluded to, is finding the time to train these endoscopists to a high enough quality standard. But now there are more and more endoscopists by profession. So rather than being a gastroenterologist with a specialty interest, they are endoscopists and specialist endoscopists with a specialist interest in a niche of endoscopy.
I mean, we're going to see this more and more, aren't we? We're going to see hospitals have, a specialist colonoscopist who's doing therapeutic procedures instead of doing a lot of gastroenterological clinics and IBD and all the rest of it. So we're going to see that more and more, I'm sure. I mean, are the ordinary general hospitals appointing pure endoscopists now? And we've got 3 or 4 or 5 here who are basically 80% of their time is endoscopy, 20% maybe gastroenterology still. Have other hospitals got that proportion yet?
Not that proportion, but one way of looking at it is we're trying to encourage now endoscopists and teams, services, to look at a lesion, and before any endoscopist embarking on removing a more complex lesion, classifying it according to one of the systems that we have. So, for example, the SMSA system, so looking at the site, the size, the morphology and the access of a lesion and grading it. And the more complex lesions should then be referred on to regional centres. Most or many centres now will have access to another centre down the road if they don't have advanced endoscopy within their own trust, and they can refer the lesions on for discussion at a polyp meeting or a polyp MDT to try and determine which of these more complex techniques the polyp should be removed by, and we would encourage people to work in this way collaboratively with specialist centres or a specialist endoscopist so that the expertise is focused.
Has that been formalised by JAG yet? Rather like, pancreatic centres have now been earmarked around the country, regional centres. Has JAG got as far as that
no,
with endoscopy?
Not formally, but as a broad brush, we're saying that really there shouldn't be such a thing as a diagnostic colonoscopist. So in years gone by, particularly perhaps, for example, nurse endoscopists, it was thought that they should not be doing any therapy, polypectomy. I was never of that belief, but that's now a no-no. And all colonoscopists, if they're competent, should be able to remove what we would call level 1 and level 2 polyps, so small polyps. And then every service every DGH should have at least one endoscopist who can take off level 3 polyps, so perhaps the bigger EMRs. And then every region should then have a centre where the level 4, the more advanced lesions, can go to, so the larger, more difficult, more challenging EMRs or the ESDs. And we're trying to develop those networks, but no, there is no formal network service yet.
That's a task for the near future.
Yes.
And you mentioned earlier on, we're coming to the end of our podcast, and I've learnt a lot, and it's been very interesting. How St Mark's and one of your predecessors, Christopher Williams, pioneered this in the UK, and we were certainly at the forefront worldwide, I think, in colonoscopy, and we still are, I would suggest. How do you think St Mark's is going to play a part in the future of this subject, which is obviously it's going to grow in importance as the demand continues to grow? How is St Mark's going to play its part in this?
I think St Mark's has always led by example and also with enthusiasm, and I think that's key. So to develop any new technique and to perfect it such that you can then teach it and share that with others, clinicians have to have the time and the resource to do that. But most importantly, they have to have the interest and the enthusiasm, and I think St Mark's will continue to do that and is doing that. What is really gratifying is that there are now a number of centres outside of St Mark's, elsewhere around the country, that also have experts, and we work collaboratively with them through things like the BSG Endoscopy Live event that now happens every 2 years. I think the other new thing for St Mark's is that we've recently appointed a whole cohort of both upper GI and hepatobiliary endoscopists, and whereas St Mark's has always focused on colorectal and lower GI, what we've talked about in endoscopy and lower GI is also happening elsewhere in the GI tract, and it would be foolhardy to just think of ourselves as being just the lower GI tract, because patients often have disease in more than one part of the GI tract, and so it's important to have that expertise locally, and we're developing that now.
So that's something for the future of St Mark's, certainly, to develop the upper GI service and research and training more than we have done. Certainly the colonoscopy days we have here are absolutely packed out with live television spectacles going on, and everybody seems to get a lot out of it. And anybody listening who hasn't been to on a St Mark's gastroenterological day or and so on might be wise to consider that. But thank you very much, Siwan, for giving us a very brief snapshot of what we do here at St Mark's with regard to endoscopy and particularly colonoscopy. And thank you very much indeed for giving us your insights.
Thank you.